Hello everyone. Okay, so today I will be starting with a new playlist which is on neurology, and I'll be covering all the important topics. I think neurology is very important in our day-to-day life, or it is actually a very good subject. I just love neurology. And when it comes to today's topic, it is a Guillain-Barre syndrome that we are having actually 2 to 3 cases per day, or we have 6 to 7 cases in a week also. So there was an outbreak also. You all are aware of it, and this is a topic which should be thorough with. I have studied this topic from Harrison with also from the other specialty textbooks, and these are the notes, and this is the way I have learned it, and I have appeared for the exam. So yeah, now please bear with me for the background music. I could not help it with. Okay, and I hope we just help each other in knowing this topic. This is really important, and this is very crucial for us to know also, because see, we have these cases on daily basis, right? And we just can help each other out on knowing this topic beautifully, so that we do not miss on something. Okay, so yeah. So now when I'm talking about the Guillain-Barre syndrome, it is nothing but it is actually a symmetrical, okay, and it is a proximal as well as the it is a proximal involvement. It is a sensory as well as the motor one, and it is acute onset, as the name suggests. It is an AIDP, right? And so this is a polyradiculopathy. This is a demyelinating one, and there is an albumin-cytological dissociation which will be there. Now this can be seen in other conditions as well, but mostly we usually it is associated with Guillain-Barre syndrome. So these are the certain points which are expected by our PG resident to know. So it is actually ascending paralysis. It is a cranial nerve which could also be involved, and bilateral facial palsy could be appreciated. Hyperreflexia or areflexia could be there. Autonomic involvement could be there in 65% of the patients. There could be a prior history of infection with the Campylobacter jejuni, or there could be a Zika virus which would be involved. And the other thing is the trauma, the surgery, and the vaccines could be also a preceding event. Now remember, there is a descending paralysis. Now this is frequently being asked. This is asked in the vivas also. Diphtheria, tetanus, and botulinum. So this is something which is a descending paralysis which would be there. So there is an Aman, there is an Amsan, there is an AIDP variant. Okay. So Aman is something which is a Zika virus as well as the Campylobacter jejuni infection could be appreciated in this patient. It is an acute motor axonal neuropathy, and there would be a wasting of the muscles as well. When it comes to acute motor sensory axonal neuropathy, which is actually a severe form, and there will be a wasting of the muscles in this as well. When it comes to AIDP, there is no wasting of the muscles, and it is the most common we see in the wards as well. There is a Miller-Fisher syndrome, which is a variant which is actually having ophthalmoplegia, ataxia, and reflexia. So this is something which could be asked in MCQ as well. Okay, there could be a case-based scenario, and there is a MCQs which are asked in the on the antibodies as well. So you are expected to know them. There is a bifacial and distal paresthesia variant, a multiple cranial nerve variant. There is a paraparetic variant. There is a pan-dysautonomic variant. There is a pure ataxic variant as well, and pure small fiber as well. Now this is something which is like you might know, you might not know. So I thought that this could be added in the curriculum as well. Okay. Um, so there is a pathophysiology. That means there are T cells as well as the B cells. Now these T cells, what will they do? They enter the blood-brain barrier, and through which with a macrophage also enter, and then they will strip the myelin, and there is actually a myelin damage which is there. So there is actually a slowing of the conduction. Okay, so in the AIDP there is a myelin damage, but in the Aman and Amsan there is an axonal damage. Now this is very important in view of a clinical as well as in view of a treatment, whatever the treatment we are giving. So this is all based on that. So this is there is a myelin damage and there is an axonal damage in Aman and Amsan. Now there is a criteria which we fit the patient in. So I feel that there is this GBS would be one of the diagnosis of exclusion. This is why, because we had a case which is actually a lady who came with a complaint of weakness in her limbs, that is since 4 hours, and we thought that we should examine, and we examined everything. So in that we got to know that there is a weakness, but the reflexes are present and the plantars are absent. So now this is a criteria. We say that there should be a bilateral flaccid type of the weakness. There would be hyporeflexia, areflexia, and this is something which is the 12 hours to 28 days. There is actually a onset. Now, we thought this is another something other than that of the GBS. So we involved the neurologist. Now, the neurologist examined the patient. He took the detailed history of the patient, and he came to the conclusion that this is a GBS. But the reflexes were present. So he said to his explanation that the patient has been in the early stages, and here the reflexes are present, and it is as well. It is actually a breast reflexes. Okay, so this is one of the miscellaneous case I have discussed with you. Not every time there would be reflexes would be present. Of course, this is actually a exception. You can also say it as an exception. This is a miscellaneous one. The another thing that is actually included in the criteria is the nerve conduction studies, and that is actually CSF and also the lumbar puncture cells. So in the lumbar punctures, the CSF cells would be less than 50 cells. That is, albuminous cytological dissociation would be expected in such patient. The third thing is the exclusion, that is the exclusion of the potassium. Like we have to rule out the potassium if there is an hypokalemia or likewise. So in the level 1, level 2, level 3, level 1, we have a clinical, we have the exclusion criteria, and we have both the investigation which will be present. In the level 2, it will be clinical with that of the exception, with that of the exclusion, with that of the one investigation, and in the level 3 we have clinical with that of the exclusion. So for the Miller-Fisher syndrome, there is certain changes which will be there in this criteria. So the clinical criteria, as the Miller-Fisher has the ataxia, ophthalmoplegia, okay, and areflexia. So there is no weakness as such, there is no loss of consciousness, there is no sensory loss, okay. Hyperreflexia, areflexia, 12 hours to 28 days, and there will be bilateral ophthalmoplegia. Investigations are the same and exclusion is also the same. Okay. So we have myelin damage in AIDP and in axonal damage in Haman and Amsan. So investigation, we do the CSF, right? And in the CSF, we have albuminous cytological dissociation. And in the NCS could be normal in the first week. This is also very problematic. So it is the clinical, whatever you are have the experiences, whatever you your senses tell you that this the patient is, and some that's why I told you sometimes this is a diagnosis of exclusion also. So in the NCS we have conduction velocity which will be decreased, the duration is increased, the temporal dispersion is increased, the latency is increased. The earliest is the F wave abnormality. This is a MCQ, this has been asked multiple times. So CSF and NCS could be normal in case of first week. Okay. The treatment, what is the treatment to such patient? Now this is very important. Not every patient is treated IVIG, not every patient is given MPS. This is really very important. Okay. So if it is a progressive, we treat. There is a minimum weakness, we wait. Okay. So there is a 20-30-40 rule. Now this is something which is very new. Less than 20 vital capacity or less 30% reduction in the vital capacity, or 30 mm there is an inspiratory pressure, or 40 mm there is an expiratory pressure. Now this is something which is from the Harrison itself I have read, and then we think that the patient should be actually treated, or the ventilatory support could be also given to such patient. Okay, so IVIG is given 2 gram per kg for 5 days, and maximum benefit is within the first 2 weeks itself. Plasmapheresis could also be tried, 250 ml per kg. They have equivalent, okay, equivalent. Nowhere it is given that this is good, this is bad, okay. The next thing is the supportive care, bed sore, infections, DVT prophylaxis, and physiotherapy. Okay. Now there are certain adverse effects of the IVIG. Headache, chills, myalgia, chest discomfort. Now there could be aseptic meningitis within 48 to 72 hours of the first dose. There could be arterial and venous embolic events. There could be a transient renal failure, and there could be anaphylaxis as well. Okay, so there is actually a variant which is actually acute CIDP. Now I will be discussing CIDP as well. So now CIDP is nothing but it is a chronic inflammatory demyelinating polyneuropathy. So which is actually more than 8 out of the 8 weeks which is actually there. Okay. But the thing is, this is something which is the acute CIDP. When we say it is more than 8 weeks itself. Okay. and there is a new demyelination that is expected. Okay? The TRF, that means a treatment related fluctuations. Treatment related fluctuations means there is a fluctuations in after the giving the treatment. Okay, so after reaching plateau or improvement, there is a fall in more than equal to 1 score. Okay, so that is something which is the more than 2 TRF is expected in this. Now you should remember these three, at least these three. One, what is this acute CIDP? Now GBS disability score, Hook score, that is you may read these points. Okay, now mostly we are not using it, but one of the interesting topic is one of the interesting chart is this Hook score. Okay, so what is the mortality? So 1 to 5% mortality is there. 80% they recover in 2 years, and 70% recover in 1 year. Okay. Now there are certain differentials. We have acute CIDP as a differential, vasculitis, sensory ganglionopathy, diabetes, porphyria, then critical illness neuropathy, botulism, then neuromuscular junction defects, myasthenia gravis, then we have HIV, CMV. So these are little bit they will be having some or the other things so that you could just differentiate GBS from. And yeah, so in the GBS there are certain few topics, few points that I would like to discuss. There is a large fiber which will be involved, so there is a tingling, numbness will be there, and that there could be a transient bowel bladder involvement as well in this, and then there could be weakness which is actually ascending. So remember, starting point is the tingling, numbness. When you ask the patient detail, okay, keep on asking him, he will say that yes, there was a certain tingling sensation, and then some patients will also experience bowel bladder involvement, and then there will be a paralysis. Okay, weakness. So this is important point. Chappal gliding with knowledge, it is a motor involvement. Without the knowledge, it is a sensory involvement. Okay. Now in the early stage there could be actually a pain in the neck, shoulder, back, or spine also. This is also important. Okay, you could not think that there could be a myelopathy and you just MRI is there, MRI you have to order like that. No, you have to think that this could also be a GBS because there is a pain in neck or shoulder pain or back pain like that. Okay. So axonal damage, we are aware of it. Axonal damage is there. Okay. So now certain topic like triggers of GBS. So one of the thing is the swine flu vaccine. Other thing is diphtheria, tetanus vaccine, OPV, rabies, meningococcal conjugate vaccine, streptokinase, suramine, heroin, Hanoptera stings. This could be a trigger. Hodgkin lymphoma is also a trigger. Surgery is also a trigger. Okay. So I hope you have enjoyed this video, and please keep on watching my playlist Neurology. Thank you for watching.